Well, hi, welcome to Habitual Excellence presented by Value Capture. I'm Mark Raven. Our guest today is Dr. Patrick Conway. He became CEO of Care Solutions at Optum in June of 2020. Before that, he was a senior executive in residence at United Health Group and Optum. From 2017 to 2019, he was president and CEO of Blue Cross and Blue Shield of North Carolina. So there's more I can tell you about Patrick's background, and I'll do that. But first off, Patrick, thank you for being here. How are you?
Great being here. Thanks for having me.
Yeah, well, I'm excited about the conversation today. There's a lot to talk about when it comes to lean and quality improvement and things you've worked on. And for the audience, if you're not familiar, Dr. Conway served as Deputy Administrator for Innovation and Quality at the Federal Centers for Medicare and Medicaid Services, or CMS as you know it. In this role, he also held the position of Director of the Center for Medicare and Medicaid Innovation. He joined CMS in 2011 as the agency's chief medical officer and served as principal deputy administrator and acting administrator, being the most senior non-political leader at CMS. So there are so many things that you've done and aspects of the healthcare system you've been involved in. But can you tell us first, how and where did you first get introduced to lean concepts, lean management, and related approaches?
Yeah, actually, so pretty early on for me. So I did a Robert Wood Johnson Clinical Scholars Program at Penn right after residency, and took classes at Wharton and other things and heard about operational management and a bit about lean then. And then my first job was at Cincinnati Children's, which has a long history in quality improvement, including using lean and IHI methods. And so really got deep into lean and operational improvement there, everything from working on flow through the hospital to working on one of my first leadership roles was leading on a unit, literally a single unit with a nurse partner on how do we improve the outcomes on that unit.
Yeah. Do you think it's easier, just as a follow-up, easier in a way to be exposed to these concepts early on in your career before the way we've always done it is established?
Yeah, it's interesting, especially we talk more about this sort of my training was pretty traditional, like most people in my area, of like learn to be a good doctor, hopefully. I'd worked at McKinsey Consulting actually before med school, so that probably gave me some basic sort of management business principles, if you will. Mm-hmm. And then I had to learn these deeper into lean quality improvement, systems improvement after residency, like I think is often the case. Hopefully over time we build these concepts in earlier. Certainly I've worked with senior executives that hadn't been exposed to it. And then, you're learning, 10 or 20 years into management. I think you can learn it anytime. And then it's, how do you apply and keep learning over time?
So you've mentioned a couple of things, but I was curious to hear more about what lean meant to you specifically as a pediatric physician and specialist.
Yeah, pediatricians are interesting. Somebody noted to me recently, well, pediatricians, a lot of you guys end up in sort of leadership roles in health systems and other environments, and it come naturally to sort of improvement population health. I think it's probably partially our training. We think about kids in the context of a family and a system of care. And so therefore, I think lean and system improvement is sort of how we're more closely aligned with how we're trained to think. And we think about whole populations of people and how we improve that population. So I do think it comes more naturally, if you will, to pediatricians. That being said, I've certainly worked with, surgeons and all different, nurses, people of all clinical types that can utilize the methodologies in their work.
Yeah. And, there is a bit of a connection. I mean, it's interesting. You talk about thinking in systems, mutual friend of ours, John Toussaint, and some others are internal medicine specialists. Yeah. And they emphasize they're looking at the whole person, maybe more so than other specialties.
No, I think that's a great example. And we'll talk more about this. I mean, John and Helen and others were great partners to us at CMS, both when he led Theta Care, when I initially was exposed to him, and then, in his current work.
And Helen being, of course, Helen Zach, who was with the Lean Enterprise Institute and Catalysis, and now she's she's part of the team here at Value Capture, thankfully. So speaking of Catalysis, when I first was exposed to you and heard you speak a couple of times at the Lean Healthcare Transformation Summit events that Catalysis put on. You were at CMS. Can you recap, at least from your memory, like what were some of the key messages that you were sharing from that CMS leadership role?
Yeah, so it's interesting. So I got to know ThedaCare more deeply when they were one of our pioneer ACOs, which was a successful program, improved quality, lower cost, and ThedaCare was one of the leaders. And then at some point in talking to John and Helen, said, I really think these concepts could apply to CMS. Like we're a huge operation. We spend over $2.5 billion a day, literally. We've got 6,000 people plus 100,000 plus contractors. We're paying claims. Just a huge amount of administrative complexity. And so we started a journey of applying that to CMS, which continues to this day. Certainly, ups and downs along the way and learnings. And so at those conferences, I think originally talked about it in sort of payment reform and the context of some of the innovation center. And then in later years, after we had applied the work in CMS, talked about the work in CMS, which led to, huge savings, more work efficiency. And honestly, the story, one of the stories I remember most was a frontline. I used to do, walk the floor, right? So CMS has got a lot of cubes because that's how CMS is structurally organized as a federal government building. And so I stopped in one of these cubes with an employee that had been there about 7 weeks, had been exposed to lean, ran a hospice quality program, and had literally already mapped out the program, like could tell me where she saw waste in the system, what she was going to try to test to, change it. And I could just see the excitement in her eyes. And I was like, this is what it's all about, right? That we've got a frontline worker who, after not being here that long, gets it, or at least gets it at a level that she's applying it and learning. And I could tell many stories like that just demonstrate, I think, the impact it had on the frontline workforce. Sorry, it's going to be a longer answer. One more point there.
That's all right.
To make sure we don't lose it. I think it was a critical component. So CMS, when I started, Don Berwick hired me, and he asked me to work with them on the culture. When I started there, in the whole federal government, every organization has employee satisfaction result, like every company, organization I've ever been on. In the whole federal government, CMS was in the bottom quartile, and the center I was about to have to lead was second to last in all of CMS. Over the course of 6 years, CMS became top 2 in the federal government, and those centers were top box within CMS in terms of workforce, frontline employee satisfaction. Actually won a public service award from the Partnership of Public Service. They ask, what'd you do? It's always multiple things in life, but one of the critical components, I think, was applying lean. Where frontline workers, they were always mission driven, but then they could see they could actually change the system. And so I think that was a huge part of our transformation journey, if you will.
And hearing, it's not surprising to hear of employee engagement and satisfaction improving. I mean, even hearing just the one example you shared, it's exciting to see the excitement in people's faces. So discovering opportunities, and they feel empowered to do something about it.
Yeah. I'll share one more story. One of our first sort of applications was in electronic clinical quality measures. And the team came in, and you could tell they were really nervous. And they said, well, Patrick, we've learned it takes us 5 years to develop an electronic clinical quality measure, and our failure rate is literally 100%. And, celebrate the horrors from lean. So I celebrated the horrors. I'm like, this is great. Like, can't possibly get worse. Like we can, all we got to do is not fail sometimes. And, let's move on the cycle time. So over time, the cycle time got down to less than a year, and then months, and the failure rate got not to zero, but very close to zero. So more of a high reliability system over that data span several years, but multiple cycles of improving. And just a great example that, you've got to celebrate the horse, that, in a positive way, opportunities for improvement. And then that team, but that was actually because I think they were nervous, like I was going to chastise them, yell at them, or be upset. And, how do you have a culture that is, you've identified the problem, now we solve the problem?
Yeah. How much of, thinking internally within CMS before coming back to, the conference and the things you were talking about there, can you talk about sort of the combination of factors of, looking at the process, viewing work as a process instead of things that just happen? How much of it is, looking at process? You mentioned aspects of management style of, like you said, getting out to the cubicles. Can you talk about how some of those factors combined?
Yeah. And so, for us, as you'd imagine, it was a combination. I mean, it's the whole system. So one was, components of that were, how do we think about CMS as processes? Let's map those processes. Let's identify waste. Let's remove that waste, similar to what you do in a healthcare system, right? We did what I've done in healthcare systems as well. We had a center, which actually was the center I led to start. Like, we'll be the test case. Then we created a central system and sort of a hub and spoke model to demonstrate successes, and then spread that like many places. And then, and we did training both of senior leaders, frontline workforce. So in different contexts I've been in, a lot of the principles have been the same. How do you have system, processes, training, measurement? We set up measurement across our processes. And then how do you systematically apply them? CMS, the other challenge, which we managed through, was you have a political turnover, which is different than, all orgs have turnover, but federal government by its nature has like an election, and then the very top people all flip. So we had to embed it in the most senior career people who don't flip. So it would go on across administrations, which it has.
Yeah. And you mentioned Dr. Don Berwick, who's of course legendary and hopefully known, I'm guessing known to most of our listeners here. Having working for him, I'm sure was a unique opportunity given his understanding of not just lean, but other quality improvement methods going back to Dr. Deming. Yeah.
I mean, I've had some amazing mentors. So Don Berwick, amazing mentor, hired me as chief medical officer at CMS when I was 34. I'm not sure I was totally prepared for the job, but he was willing to teach me. Uma Kodagal, who I'm guessing some of your listeners know, who was like legendary at Cincinnati Children's. She was one of my first mentors at Cincinnati Children's, really teaching me about systems and the approaches, and is still a mentor to this day. Same with Don. We're still in touch. And so, I've had, and John Toussaint and others, I've had the blessing, if you will, of learning from some amazing people over time. And I try to pass that on to others now.
Yeah. So speaking of passing things on, when you were speaking at the summit, I think, me as an engineer, I'm focused on the process, on the management system. Let's not just do things better, but let's do the right things better.
Yep.
And the one thing that I always learned the most from at those events was the healthcare economists or people like yourself who were talking about the impact of payment systems, whether it's, it's just reimbursement or incentives. I was wondering if you could share, some thoughts or even how some of those thoughts have evolved of, how important is the role of having the right incentives in place to help drive the right improvements in the right ways?
Yeah. So I think of payment, and this may surprise some listeners, given I ran a payer at Blue Cross North Carolina. I think of as payment as necessary but not sufficient. It can be an accelerator or it can be a barrier. So what I mean by that is, if we shift to true population-based payments on one of the spectrum, I'm going to pay you, per member per month, adjusted for quality and experience and risk adjustment to care for a population. I think that unleashes innovation, whether it's in data care or any other organization in the country. Of, all right, I've got a known financial flow with known incentives on quality, experience, and total cost of care. I'm going to innovate. I'm going to do telehealth. I'm going to think about my visits differently. I'm going to care that's not needed. I'm going to get it out of my system. On the other end of the spectrum, in a full fee-for-service environment, I've literally, unfortunately, had CFOs say, and not to pick on CFOs, but it's often a CFO, say to me like, "Hey, I need heads in my beds," which is like, oh my gosh, like is there any patient that wants to be the head in that bed? Like, no, nobody. I work in the hospital still to this day. Nobody wants to be there. They want to be home. They want to be out of the hospital. So, so you got to get rid of that countervailing incentive and have a financial incentive that allows people to align with what the patient, the health system, we would all want.
Yeah, well, and to take the heat off the CFOs, and this seems like, from my experience, such a common dynamic. A CEO at a system I visited maybe 2013 or so, who was a physician, had been CEO of the system a long time. They were doing great work with lean. This is when readmission rates were getting a lot of focus. And he drew a couple curves on the whiteboard of like, here's how quickly we could reduce readmissions. The problem is the financial impact of when that would bankrupt us.
Yeah.
And that's a tough situation.
No. And I shouldn't pick on CFOs either. CEOs. And you do get into real issues of how you manage the transition. I think what I'd say there, I think sometimes we use finance as a crutch or a barrier when the real issue is like fear of change. So, to take it to North Carolina, we shifted in Blue Cross North Carolina from almost 0% of payments and true total cost of care, quality experience models to over 50% in less than 18 months. Honestly, with the health systems there, we just said fee for service is not an option. So let's stop talking about that. And let's shift it. And then let's talk about how we construct a contract and a relationship that works in a value-based way for you. And let's have the give and take there. But we have to move past the well, I can put it off another year. I can delay the change because I think the change needs to happen. So hopefully we have more health system leaders and health plan leaders, honestly, and others that, will enable that change.
And it'll be interesting to see what continued experiments or innovations come from a payment and reimbursement standpoint.
Yeah, I agree.
Thinking back to maybe final question about your time at CMS.
Yeah.
Was there a role or what was being done to encourage, when you talk about payment systems being necessary but not sufficient? The other piece might then include process improvement, lean management, all those things. Was there a role? Is there a role? Should there be a role in somehow directly incentivizing or encouraging that type of work in the healthcare delivery organizations?
I do think so. And some of this, honestly, I think is less now out of CMS than it used to be. And hopefully it ramps back up in the current administration. So we had purposeful funding to assistance, if you will. So Partnership for Patients was on safety, dramatic effects, and Don started this, but dramatic positive effects on safety that funded, coalitions working together. How are we going to measure results? How are we going to drive change? Let's drive systematic change. The Transforming Clinical Practice Initiative, working with hundreds of thousands of physicians and clinicians around America, same idea, driving change. We used to have, and I think they still have to some degree, learning models around all the CMMI models to really have the participants learn from each other. We shouldn't lose that. It's not as, I'm going to use the word sexy because I can't think of a better word, but it's not as the policymakers often go to what are the dollars and cents? Give me the exact results for this payment model because it's more, you can calculate that. In my experience, once again, it's necessary but not sufficient. How do we create a system around the participants and a set of incentives that supports them? One of the models that actually worked really well was this advanced investment model where we literally put in funding and technical assistance to small providers and rural providers to participate in ACOs, and it worked very well. And I think it's a great example. They needed that support to succeed. And so I just think it's another example where that has to occur if we really want the transformation to occur.
Yeah. So let's shift, Patrick, maybe and talk about some of your time, at Blue Cross Blue Shield of North Carolina. What was it like as a CEO of a payer, and where was your head in terms of lean, being quote unquote a lean leader, if you will, and using that within the organization?
Yeah. So what we talked about in North Carolina is we were trying to be a model of what a blue plan could be, or a model of health transformation. And so at its core, we said, we insure 60+% of people in North Carolina. Our mission on the wall. We should care what's written on the wall. Says it's to improve the health and well-being of the people and communities in North Carolina. So how are we going to invest in that? So that was the core frame. And that was different for Blue Cross North Carolina, and I think different than many health plans in America, and sort of a cultural shift. And that took some time to make that cultural shift. Then that leads to like, okay, how do we partner with providers to drive that change? How do we work on our own systems using lean to drive out waste so our administrative costs go down? Because premiums are medical expense. I used to always say this again and again because people forget it. Premiums are medical expense plus administrative expense plus in a Blues plan, a small margin, because it's a not-for-profit Blues plan, to reinvest. And so like if we bring down medical expense and we bring down administrative expense, premiums go down. And actually in North Carolina, to give you some numbers, premiums went down for the first time in the state's history. So ACA premiums went down more than 10% year on year. Medical Advantage premiums for North Carolina went down more than 33% times 2 years, down to zero. So like every plan's premium was zero. And the employer premiums, in general, employer premiums vary by county, et cetera, but employer premiums were close to flat to negative. That doesn't happen in healthcare often. And it was a combination of medical expense and administrative expense. Certainly didn't do everything right, but that was the transformation we were trying to lead, including, and we talked about, if we're going to ask providers to drive out medical expense, we've got to have the same level of focus on our administrative waste processes expense. Actually, one last example. We even got rid, to your point, lean is not just improving the current processes, it's getting rid of processes. So we had like prior authorization processes. We're adding no value to anyone, like some of them. So we just got rid of them. And like providers were like, oh my God, like, thank you. Like, I don't have to do another prior auth. But we had processes where we were doing prior auths and improving 99.99% of the time, but a bunch of back and forth of paper and faxes and like things that would make you sad. And so like, let's just get rid of that.
That's fascinating because I mean, you hear other companies in different contexts of, travel requests or different administrative things where, like you said, if the approval rate's almost 100%, why do that?
There's so much waste. I mean, with one of the health systems, they were like, we have thousands of people in our back office fighting with your back office people about prior auth. Like, that's so much waste. And like, some of it may be necessary, right? There may be some things where you really, it's nuance, but like, the example I gave is a real one where we had not a small number that it was quite obvious it was waste. So let's just get rid of them. The other thing is when you partnered with a provider in their risk-based relationship, you don't have to micromanage every service because you're in a different payment model.
Now, is there a role, I'll think of, put my patient hat on. Is there a role for a pre-authorization or some consultation with the insurance provider to help make sure that I'm getting what's considered the best standard of care?
Yeah, I think so we're in life, I think sometimes we don't apply the nuance. So some people sometimes say like all prior auth is bad. Well, that's not true because when it gets to your point, like I was talking to an orthopedic surgeon friend of mine and he was like, don't tell me, I won't say his name because he was like, don't tell any of my other orthopedic surgeon friends I said this. I have a musculoskeletal company that reports into me in our structure that does prior auth for like complex orthopedic procedures. And I was like, what do you think about that? And he's like, you should keep doing it because a bunch of my colleagues are literally doing surgeries that in the literature have been proven not to help people. But if you go to your doctor and they say you need this shoulder surgery and you get it, you assume it was evidence-based, but unfortunately it's not always the case. So from that perspective, in that instance, a prior authorization will get the patient what they need. Patient engagement, I think, should happen more broadly where we have true patient engagement. That's a longer conversation, but how do payers and providers really have shared decision-making with patients and families on these kind of things?
Yeah. And there's evidence-based, but some of that evidence might be older than the new evidence. And so that's the challenge, it seems.
Yeah. And this goes even back at Cincinnati Children's. I did this project on evidence adoption where the ID docs and the hospital medicine docs, which I ran, disagreed. So it's like, okay, let's just explain it to families. Do they want long-term IV antibiotics or do they want to try the oral? I actually thought most families would pick oral because imagine a PICC line in your 3-year-old. 90+% chose oral, and it worked. So like, when there's older evidence or unclear evidence, let's engage patients in the decision, give them the information, let them make informed decisions.
Yeah. So final thing I want to touch on here, Patrick, being CEO of Care Solutions at Optum. First, can you tell the listener a little bit about Care Solutions, how that fits into Optum and what you do?
Yeah, so I've got a set of businesses, mostly care delivery. I live all our home and community businesses. So they take risk and deliver care, physical, mental, and social for people in their home all across America, millions of people, both episodic and full risk for years, for dual eligibles, Medicare, other people across America. That's our home and community businesses. I run all our post-acute businesses, so think transition from hospital to home and how you transition well. We lead all our mental and behavioral health benefit and care delivery businesses. So 40 million people that receive benefits from us for mental and behavioral health, and then care delivery, both virtual and in person, for depression, anxiety, substance use treatment, you name it. All our specialty care businesses, renal, oncology, name a specialty, and our acute care businesses like hospital medicine and other things. So great portfolio of businesses. And what I get most excited about, serves, all in, we in the Optum health care delivery part of Optum served 99 million people last year. And so we have a significant ability to impact our health system. We have over 55,000 doctors. It's a large care delivery system across the U.S., working with our partners at United Healthcare, but also 9 out of 10 payers in the U.S. and 8 out of 10 health systems. So you're really working across the whole system.
And so what does it mean for you then as CEO? I know you take opportunities to go to the front lines, in a home health setting and during a pandemic. What has that been like?
Yeah, a couple quick things. One, I'm still a practicing physician on weekends, so I take care of kids in the hospital. So I see the system from that perspective as a volunteer attending on weekends. To your point, I go to the front line of our businesses. So I went on a visit with Landmark, which was one of our businesses, to a 91-year-old in her home the other day. And first she's like, hugs the doctor when he comes in and is like, "You saved my life, blah, blah, blah." It's like, I used to get hospitalized 6 or 7 times a year. I've been hospitalized in 18 months. Showed me what we've installed in her house, social needs, showed me like her medication reconciliation, physical needs, actually had some depression issues after she's a widower. So dealt with some of her mental health and well-being and social isolation issues. Like, that's amazing. And I do these frontline listening sessions with our nurses and nurse practitioners and others delivering the care. That's where I get my energy. Honestly, we got a lot of finance. I don't get my energy from finance. You gotta work, you gotta deliver on financial things in life. But, where I get my energy is from the frontline clinicians and others. And, I did a frontline session the other day with people who answer the phones. So we got people calling in all the time and they're answering the phones. And we talked about how do we set up the system so they can help people as fast as possible? How do we give them the data and the information they need at the point of that phone call so they can help people? And that's what they want to do. So how do you tap into that sort of mission-driven nature to give people the information they need to drive the change that you want?
Mm-hmm. And even with the pandemic, you're going out with masks and just doing.
We are, so all the protocols.
I
started here right before COVID started and was supposed to work on home and community and mental health. So, you can't make this stuff up, right? So then COVID happens and mental health, the need explodes in an already challenged system. So we've been working on that throughout. And then in the home and community, you have a period where you're like, how can I safely get to the home? And we got to switch everything to virtual. And now we're back into yes, we need virtual, but we need to be in people's homes again, but safely. It's been a challenging time, but really rewarding.
Yeah. Was there an effort, considering the role of home health, to bring COVID vaccinations to patients in a lot of cases?
Yeah, we don't get to talk about that much. So our setup, yes, is the short version, and we are one of the largest COVID testing and COVID vaccination entities in the country. So we've done it both for our patient populations. We've even supported whole states So California, North Carolina, Indiana, others, where we become their delivery arm, including mobile delivery, where we'll put nurses in vans and go to communities, for example, underrepresented communities or communities with health equity issues, where then we deliver the vaccines in the community to try to increase rates. So it's been, once again, challenging, but really rewarding work to try to help solve some complex problems.
Yeah, definitely. So maybe a final question. This will be real open-ended, is more of a reflection question. But you said you got exposed to a lot of these concepts very early in your career. You had relatively early mentorship from Don Berwick, and as you've gained experience learning by doing as an executive in different settings, is there a key lesson learned along the way that you would want to pass along to others that it would be better for them to learn earlier as opposed to later, whether it comes to leadership or healthcare improvement?
Look, I haven't planned out my career, nor could I predict it, including I've had huge dramatic failures, quite honestly, including public. For me, if it's helpful for others, I've had 5 criteria that have guided me through. One is family and faith, which I know is 2, but I combine them for a reason.
Yeah.
2 is impact, which I think of as the triple aim before I knew what the triple aim was. So quality, experience, total cost of care, populations of people. 3 is people, so mentors, people I work with, culture, and that's changed over time. I've taken jobs that are like, I want to work with that person, I want to learn from them. Related. 4 is learning. Am I learning, and at what pace? And 5 is joy in work, which is self-explanatory. So for me, including in the last transition, I went back to those criteria, and our family went back to those criteria, and that led me to where I am now. I get asked, what do you do next? I'm like, it's not how I think. I mean, I think, how am I going to work in this, whatever system I'm in, to improve it on a day-to-day basis? Last thing I'll share, when I interviewed for the North Carolina CEO job, I literally said to them, they said it stuck with them, I mean, I'd never run a health plan, and they gave me that job. And so I said, I won't be the best on day 1, month 1, but I'll be the best at getting better. And in my current role, certainly wasn't the best when I started. Still not the best role. But I work really hard at getting better, and I want our system to work really hard at getting better. So hopefully that's helpful.
I think so. That's very well said. I love that that idea of being the best at getting better. The joy you have in your work comes through in hearing you talk about these different steps, and it brings me some joy to be able to interview you. So thank you.
Thank you.
Thanks for being a guest and sharing with us today, Patrick.
Thanks a lot.